Good afternoon and welcome to our medical lecture series. I am Dr. Galat Hakim, Assistant Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health International. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America and the Caribbean and everybody joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located in the bottom of your screen. I will be your moderator for today's lecture. This afternoon, I have the distinct pleasure of having to introduce Dr. Priscilla Escalona. Her presentation is titled Endocrinology, Advanced Diabetes Technology. Dr. Escalona is a board-certified endocrinologist at Baptist Health. Dr. Escalona Villasmil treats patients with diabetes, thyroid conditions, metabolic disorders, pituitary diseases, among many other conditions. Dr. Escalona received her medical degree with honors from Universidad Centro Occidental Lisandro Alvarado in Venezuela. She completed her internal medicine residency at Stewart Corney Hospital in Boston, Massachusetts, affiliated with Tufts University School of Medicine, where she entered and earned the Best Teaching Resident Award. Following her residency, she completed an Endocrinology in Diabetes and Metabolic Disorders Fellowship at Tufts Medical Center. Prior to joining Baptist Health in 2023, Dr. Escalona worked as an endocrinologist at Prisma Health in Greenville, South Carolina, for several years, really. She also taught as a clinician assisting professor at the University of South Carolina School of Medicine in Greenville. Dr. Escalona has presented several abstracts and posters at various professional meetings, both nationally and internationally. She is a member of several professional associations, including the Endocrinology Society, the American Association of Clinical Endocrinologists, and the American Thyroid Association. She speaks and is fluent in Spanish and English, and we are so very pleased to have Dr. Priscilla Escalona with us. Thank you so much for accepting our invitation and welcome. The floor is all yours, Doctor.
Perfect. Thank you so much, actually, for having me here, and thank you for all joining today for this presentation. Okay, perfect. Okay, so well, our topic today definitely will be advanced diabetes technology, specifically continuous glucose monitoring devices that we have available in the US right now, and we will go into the way they work and actually all the data around this up to date. So okay, so diabetes technology, even by the American Diabetes Association. So this is all the hardware, devices, and software that nowadays people can actually, with diabetes, can use to manage their condition, even from lifestyle to determination of blood glucose levels. So by definition, what technology involves is even insulin delivery or actually checking blood sugars or glucose monitoring, either by finger sticks or blood glucose monitoring or continuous glucose monitoring devices. And the administration of insulin, by definition, has been either by syringes, insulin pens, pumps, or even smart pens. But nowadays, even diabetes technology includes actually an expand, especially for the last few years. It has been definitely so many new devices and so like a huge actually improvement in terms of insulin pumps that even now we include the automated insulin delivery systems, which works with continuous glucose monitoring and or even pumps or pens. And this way, actually, patients can manage better type 1 or even type 2 diabetes. So going actually just to give you an overview of diabetes technology over time. So since actually discovering of insulin back in the 1920s, it has been 100 years of amazing things actually in the diabetes field. But precisely for the last 20 years, and even for the last 6 years, we have had actually, of course, along with all technology, we have had a huge actually development of technology, even leading to bionic pancreas. So as you can see in this timeline, we have the use of insulin pumps for the last 30 years. But since 2016, we have automated insulin delivery systems, the closest that we have to artificial pancreas technology. We have different devices, different pumps, continuous glucose monitor, and even here I'm pointing for your reference, even now the approval later last year of actually iLet, that they're working into artificial pancreas technology and delivery of glucagon along with insulin. So the last 10 years has been a lot of actually research, discoveries in terms of this. So I'm just going to go actually to review a few things to understand better how we use continuous glucose monitoring and the data in all actually the rationality behind its use. So just by the American Diabetes Association standard of cares, definitely A1C, since pretty much for the last 30 years, 20 years, it has been the standard of care for us to assess glycemic control in patients with diabetes. However, we have seen that now with all technology coming up, to better assess a patient, we actually use A1C measurements, but we have tools like blood glucose monitoring, even by finger sticks, besides the use actually of CGM, so continuous glucose monitoring. This is the latest actually glycemic recommendations in non-pregnant patients. In terms of A1C values, we try to aim at A1C below 7%, fasting blood glucoses around 80, 130, and then peak postprandial capillary determinations no higher than 180. This is pretty much the recommendations even updated in the standard of care published in 2024. However, definitely now we're also recognizing a few things actually in the importance of individualized actually therapy and actually targets based on our patients' actually conditions, even from disease duration, life expectancy, and comorbidities, including cardiovascular disease. So this is actually how we can assess, okay, we have a patient, elderly, with heart disease. We're not going to actually be that strict, achieving an A1C of 7% when we can do that expenses of patients experiencing hypoglycemia. So even sometimes per patient preference, sometimes we see patients with type 1 diabetes for years that they have such a fear of hypoglycemia that they feel comfortable at some point and with an A1C that is not going to be below 7, but close to it, but without high blood sugar. So definitely now the approach to diabetes patients, it's definitely individualized based on medical conditions and a lot of factors. Even socioeconomic factors is also a very important feature that we consider. So going back into the continuous glucose monitoring, so how we do this? This is our devices, and I'm going to go into how they work in a few minutes. But we have the way to access this information, to even download reports, which I'm going to show to you, and then see how the patient has been doing more recently, 2 weeks from 30 days or even 90 days, and give actually a glycemic assessment, like very deep. Time in range is a concept that we use significantly in continuous glucose monitoring. And it's actually the time in which a patient is achieving our target goals. By definition, this has been from 70 to 180. And based on the time that patient actually has been a lot of research to determine what is the time in range and the association with the actually improving risk of microvascular complication. So that is what we're going to be reviewing step by step during this presentation. So time in range. So this is actually what are we expecting in a patient with type 2 and type 1 diabetes without comorbidities. So target range is 70 to 180. Of course, fasting targets, as we mentioned before, will be lower. But if you see our expectation actually when we read these devices or we interpret the data from these devices is that 70% of actually the time we are achieving this target. Of course, we're going to expect some highs, but as you see, readings higher than 180 shouldn't be more than 25% of the time of the data that we are analyzing, and even higher than 250 of glycemia, less than 5%. And more importantly, lows is also a very important to assess. Readings below 70 by CGM, definitely we're aiming that patients will be less than 4% of the time and less than 1%. So this is actually the goals by an international consensus after reviewing all the data and determining, okay, what is the target range that will correlate with a specific A1C. 70% correlates with an A1C of 7 on clinical studies. So these apply differently in older patients, high-risk patients, patients with like a lot of variability in type 1 diabetes or type 2 with cardiovascular disease, history of coronary artery disease. We are less strict. And if you see the target range drops from 70% to 50%, minimizing the hypoglycemia risk. So in this patient population, it's very important to avoid hypoglycemia, and we expect less actually than 1%. For type 1, and actually in pregnancy, these devices were not approved to be used in pregnancy until last year. But definitely pregnancy is like one of the states that we try to achieve a better control to avoid, fetal and maternal complications actually. And our target range by definition is even tighter. So from 63 to 140, and by definition, high blood sugars or postprandial hyperglycemia in this patient population is 140 or above. So this is actually has been even for type 1 in pregnancy and for type 2. For type 2, given lower risk of hypoglycemia compared to type 1, even the timing range has not been necessarily determined, but we expect be less strict than with type 1s to avoid hypoglycemia. So as I said, more research is needed in terms of pregnancy. However, these devices, CGMs, and specifically a few ones that we have in the market has been approved last year to be used in pregnant people. So this is actually the concept of timing range and how it's important, because this is actually 3 patients and we see the different phases of a single A1C. So we have, these patients may have A1Cs of 7, but when we actually use this kind of devices and technology, we can assess specifically the degree of glycemic variability. So we have patient A, A1C of 7, but if you see only 40% of the time these patients are in range, and they have 20% of the time that the readings are going low, as you can see below 70. The same different patient with the same A1C can have 70% time in range, minimizing actually with lower lows. But if you see even a patient with actually less glycemic variability can have also an A1C of 7 and be within target range most of the time. So that's why integrating actually the information that we obtain from these devices plus A1C, plus it will allow us to make treatment decisions in a better way, especially on insulin-treated patients. So this is just a brief orientation in a few of the devices that we have approved by the FDA in the United States, just like basics of CGMs. So the continuous glucose monitoring actually has 3 aspects. So we have a sensor that is actually in the interstitial, space. So the sensor measures glucose in the fluid every 1 to 15 minutes. It depends on the device. It's actually not a needle. It's actually just like a plastic, like a small catheter, and it goes actually in the subcutaneous tissue. So the data transmitted automatically to a receiver. A few of the devices can use a smartphone as a receiver or have a separate device, but that is the device that will receive all the data. The user actually can pretty much see the data, and then the data is presented as a glucose value with different aspects like trends, graph, or things like that I will show in a few minutes. But that is pretty much the basics. So also another thing to understand, and also that we need to explain to patients, is that there's going to be some sort of delay, and this is important to understand in a few situations. So first of all, it's going to be a physiologic delay. The sensor will not actually determine glucose from blood. Actually, it's from the interstitial tissue. So there's going to be like some delay, the time that actually is the diffusion of glucose from the intravascular space to the interstitial fluid, and then all the time processing all the data so that the transmission from the sensor goes into the receiver. So this is actually what we call time lag. That could actually explain why patients sometimes they say, well, my numbers are so different by the CGM when I prick my finger and I check it by finger stick. But that is actually very important in this scenario. When glucose are stable, the sensor readings and the blood glucoses are very similar. So it's a very steady pace. The problem will happen and the mismatch will happen when the glucose goes up or down very quickly because of all the delay in the transmission of the information. So when actually the blood glucose is going up quickly, you can see a mismatch and the sensor readings will be lower than the blood glucose reading. And more importantly, when people is experiencing hypoglycemia quickly, the sensor readings can be higher than the actual blood glucose. This is a patient that could be having symptoms and they check and the blood glucose by the CGM is not even below 70. But this is a very important concept to explain to patients so that they can do that to any kind of decision in terms of treatment or, insulin for corrections or even taking corrections for hypoglycemia, they should check finger sticks. So as glucose may even change actually and differ more than 20%. So how the continuous glucose monitor can help patients. So this is actually a typical patient that we have, checking blood glucoses. And if you see, they're normal when the patients check actually. So what happens is even if the patient is checking 4, 5, 6 times daily, they're doing in a single point of time. When we actually translate or combine this data with a CGM, this is what we can see. So sometimes patients using actually only finger sticks, we can actually miss information, especially patients that do not develop hypoglycemia unawareness in cases of, low blood sugars. But here is how we can combine the information together. And you see that here we have data 24/7. So that is what is so, informative and critical for decision making in our field nowadays. So we have different CGMs available in the market. So we have actually real-time data. Pretty much they measure and store glucose levels continuously without prompting. And definitely that's the CGMs that are working along with insulin pumps in automated insulin deliveries. We have intermittently scan. It's only one device actually that we have available, as I will say. But this is actually the patient need to scan the sensor to store the glucose values, and the patient actually needs to do it at least 4 times daily to be able to store all the information. So this is pretty much at the beginning when we didn't have that many CGMs available. Usually patients treated with non-hypoglycemic therapies, patients on weekly injectables like GLP-1s or metformin, or simply actually based on patient's preference. But this is the 2 kind of CGMs that we have available in the market. So nowadays, even up to date, we have several devices approved in the US. We have different brands, actually from Dexcom. We have G6, G7. We have Eversense, that is the only one that is lasts 6 months and is actually implantable under the skin. We have Guardian by Medtronic, but that works actually with their own insulin pump. And we have Freestyle Libre that even in the last 4 years, it has been evolving so much that it has 3 different generations. So 1, 2, and the latest one, which is Libre 3. So for actually in our office, also we have these devices, but for professional use. Actually, this is the devices that we place on patients in our office for X amount of time. Usually depends on the length of, and the duration of the sensors. But this is patients that we just need data to adjust, treatment, especially we use it on patients with newly diagnosed diabetes, patients that do not check finger sticks at all, and we don't have any data. Problematic hypoglycemia, but they don't have access to a personal continuous glucose monitor, or patients actually with type 2 that they just actually want to have this as an educational tool, and people that wants to actually learn more about this technology before engaging to have one on their own. So we have two professional systems, which is Dexcom's G6 Pro and Freestyle Libre Pro. So this is mostly available in our offices here, and we do it actually specifically. We place it for patients, and then we bring them to review the data. So this is actually a very heavy slide, but I just want to bring a few key points of different sensors, especially the way that patients may decide. Usually here, it depends of the insurance coverage and the patient's preference, but there are a few things actually that we explain. If it's real time, so most of them nowadays are real time, except Freestyle Libre, which is actually the one that needs to be scanned 4 times a day, or it's intermittent. Also important is sensor life. Freestyle actually is 14 days versus 10 days. So that is how frequent the patient needs to change the Dexcom, the sensors. Dexcom G7 has a 12-hour period grace, but also is 10 days. And Eversense is the only one actually that is even up to 180 days, but this is actually implanted in the upper arm. All of them are approved based on the clinical trials that granted approval. In a few of them in the abdomen, other of them, can be back of the upper arm, and things like that. Calibration also is very important. A few of them, actually most of them nowadays, are factory calibrated. So that means that you don't need to check finger sticks to assess accuracy of the data. You could do it, but they're factory calibrated. The only one that needs to be, we need to correlate with finger sticks, is Eversense, which is the one that I'm telling you is implantable, and it's just pretty much but even twice daily. And then Guardian 3, actually, even this specific company, Omectronic, is working actually on Guardian 4 that doesn't require actually calibration. And also importantly is the calibration with insulin pumps. Now we have, even last year, approval of modified sensors for Freestyle Libre 2 and 3 that will be able to work with tandem T-Slim X2 insulin pumps. But Omnipod 5, all the pumps actually has some sort of integration with CGMs. Also importantly, which ones can be used with a different and separate receiver. That patients, let's say that they don't have a smartphone or they don't want to use their own phones. For imaging studies, also this is important to explain to patients that definitely they cannot be actually used if a patient is going to have a CT scan, an MRI. The only one that is MRI compatible is the implantable, because actually you can't remove part of the implantable device is actually compatible with imaging studies. It's the same that applies when patients are actually going and traveling internationally or even locally. So they cannot go into the body scans. They need actually to go to metal detectors or things like that. In terms of accuracy, that is actually checked on clinical trials as a mean absolute relative difference. And if you see actually all of them nowadays, for the last 10 years, all these new devices has been very accurate, being the one of the most Freestyle Libre 3 and Dexcom G7. So also warm alarms, that's very important. These devices are gonna actually provide an alarm in cases of high and lows, and they have, Dexcom especially, they have actually predictive alerts. That means that the patient will get a notification if the sensor is actually detecting that the blood glucose is dropping quickly. The only one that doesn't provide alarms is the Freestyle Flash or first generation. So they have the train arrows, which is actually the patient gets a notification if they're going up or the blood glucose is going down. they can share the data with their relatives. Even you can actually do it if you're doing your smartphone. Other people can have access actually to your sensor. And also, this is a concept very important to explain, is that the determination of glucose can be affected by medications and things that patients can actually obtain over the counter, like Tylenol, like vitamin C, and a few medications that we use actually in the hospital. However, the most is vitamin C. All the libres actually can be affected, and they may falsely elevate the sensor readings. And in the case of Medtronic Guardian, Tylenol. So patients that need and require like Tylenol on a daily basis, that also actually may false elevate the sensor readings. But that's pretty much like an overview of the sensors that we have in the market right now. This is the professional system that I was explaining to you. They could be, the Freestyle Libre is blinded. So that means that the patient doesn't know what is happening. It doesn't provide any alarm. We just download it when the patient comes and we review the data. Dexcom G6 could be blinded or unblinded, so the patient has the opportunity to see what is happening. This is more like a learning experience for patients that have never been on CGMs, because they will see the variations actually of the numbers in a way that they could use a personal one. So this is new. This is actually approved by the FDA March 2024. This is Estelo. It's a glucose biosensor system. This is the only sensor that can be found over the counter. So it will be available in a few months, summer 2024. It's designed actually for patients that are not on insulin. They just want to check the blood sugars. It's indicated for patients 18 and older. Of course, it will not have any integration to any insulin delivery system. But this is actually 15 days, and it's a way that patients can avoid checking with finger sticks. And this is recently approved and will be available in the market actually summer 2024 for patients even without diabetes, that they just want to check their blood sugars, pre-diabetes and so forth. They just want to monitor. So just reviewing accuracy over time of these devices. So as I said, we have had continuous glucose monitor even since early 2000s. As you see, as time passes, actually they get better and they get more accurate. So actually they have the side of this screen as the one that I just explained to you. And as you see, the accuracy has improved significantly over time on all the devices. So what is the recommendations actually? So based on the American Diabetes Association, the most recent update, before, like a couple of years ago, this technology actually was reserved for patients with type 1 or patients with type 2 that they were on MDI or multiple, injections regimens. So patients that were on basal insulin and pendrive insulin. But now they're expanding actually the recommendations to other diabetics that also will benefit from this technology and they're not on insulin. But for recommendations, we need to actually, these devices are pretty much considered standard of care for diabetes management in patients, either type 1s, of course, type 2, that on multi-daily injection regimen, or even on basal insulin. So for type 1, it's actually pretty much recommended even as a child in, or in the youth, they should be able to offer these devices. And definitely, this is actually a standard of care, especially for type 1 diabetes. In pregnancy, as I mentioned, Dexcom G7 and Libre 2 and 3 has been recently cleared by the FDA for use in pregnancy, which didn't happen before. So that way, actually, patients can track blood glucoses, especially postprandial readings, which are the most important, definitely to avoid complications during pregnancy. And definitely we need to advise patients that, of course, every time they come, these are devices that are placed in the skin. They can have tapes, although they're latex-free, but we need to assess skin reactions and how the patients are doing, and definitely educate the patients about interfering substances, like I said, like Tylenol, and like like vitamin C, that can affect the accuracy of the glucose determination. Also, other societies, like the Endocrine Society and the American Association of Clinical Endocrinologists, even on their later upgrades in terms of diabetes guidelines, they also recommend CGMs in all persons with diabetes, type 1 or type 2, treated with insulin therapy, patients with problematic hypoglycemia, patients with type 1 in youth, pregnant patients, and definitely it has been actually, as I said, the latest from FDA has been expanding the recommendations of every patient with diabetes pretty much using these devices. So what is actually the same way that we have like landmark studies in our field, like the DCCT and the QSPS. So the importance actually correlating all this data is to see what is happening, are patients better controlled, and what is the probability of progression or development of complications. So this is actually have been large randomized clinical trials, especially on the efficacy in patients using CGMs, either type 1 or type 2. This is actually a few studies, and they have been pretty much having all these outcomes. Even in patients with type 2, we see reductions on A1C, just patient, even without even medications changes, but just the fact that patients know and they track better the blood glucoses, definitely A1C has been coming down. Importantly, reduction of hypoglycemia, especially of type 1 diabetes, with reduction of those upside downs or what glycemic variability, improvement of life satisfaction, and mostly distress due to hypoglycemia. One of the main challenges treating a type 1 with frequent hypoglycemia or hypoglycemia unawareness is actually that they have a lot of distress and they don't want to increase dosages or do changes just because of this, and we are not able to achieve our goals. But now we see improvement or have a lot of outcomes in this matter in the use of CGMs. So this is actually a study that I like to bring on because it's type 2 diabetes only on basal insulin. And this actually was published a couple of years ago on JAMA. It's actually in the primary care setting because this actually technology is available also for primary care physicians, internists, family medicine providers. It's not exclusively to be used by endocrinologists. So even in this study, they saw that patients actually just with continuous glucose monitoring, we see even 1.1% reduction of A1C in 8 months without significant changes. All of them were on basal insulin. So even with glucose meter monitoring, we see reduction, but not as significant as patients with CGMs. This is a study. It has definitely 15 primary care practices in the US, but it's even patients just on basal insulin. Also, is the same. From this study, to the patients, a few of them discontinue actually continuous glucose monitoring. They just continue checking finger sticks. And we see that at the end, actually, of the end of the study, over 14 months, we see actually some bumps in A1C, in mean A1C, in patients that they discontinue the glucose monitoring device use. Also, more importantly, the same way as I said, we correlate A1C. So we try to achieve an A1C less than 7 just to decrease the incidence of microvascular complications. So the same apply for what we call the time in range. So that is actually the most important, one of the most important metrics on CGM data. And we have seen that improving the time in range the patients are at target, we have seen decrease of complications, even 50% reduction in macro and micro complications with improvement even of time in range. So definitely we have seen an increase in decrease in retinopathy, nephropathy, and neuropathy, and even patients that tend to experience like the first major adverse cardiac event or MACE. So this is actually the same. This is a study published a couple of years ago about the validation of the time in range as an outcome in diabetes clinical trials. So we see in terms of retinopathy and microalbuminuria that for 10% less time in range, the progression increased by 64%. So definitely keeping the numbers within target that will prevent definitely the progression of the incidence of these two microvascular complications. The same will apply actually for a few of mostly even macrovascular complications, hospitalization for hypoglycemia and DKA in type 1 diabetes. So patients actually keeping time in range more than 70%, that means less hypoglycemia and less hyperglycemia. You see actually lower prevalence in terms of every outcome and even composite of the microvascular outcomes. So that is important. Actually, definitely we're achieving not only a number like an A1C, is simply just working in glycemic variability. So also even neuropathy. So patients actually, this is a small study done, a couple of years ago in China, but they saw that also time in range correlated actually with improvement of painful neuropathy, regardless A1C or glucose variability. So they saw that patients that were having better data, the pain improved. So cardiovascular perspective, the same. So even if a patient has the glucoses up to 85% of the time within target range, you see the cardiovascular mortality decrease significantly and all-cause mortality as well. The same will apply. So pretty much on this study, they saw patients actually just to see the probability of a major adverse cardiac events defined by stroke or actually infarct, STEMI, and they saw that patients will spend more time in range, definitely, like pretty much. So more than 70%, they were likely to experience a lower rate of first MACE or major adverse cardiac event. So just to give you, so this is actually just briefly, this is a patient, and we see this in clinical practice very often. So you have a patient that is compliant. Patient is actually on 3 regimens, including basal insulin, insulin glargine every day, taking metformin and liraglutide or Victoza on daily basis. So patient comes with her finger sticks, actually with her logbook. Fasting blood glucose are definitely reasonable, with a few elevated by most of them within target. And then a few bedtime readings could be a little bit high, but this is the patient that said, I do everything, I take my medications, and I cannot lower my A1C. So what happens when we have this technology in hand? So this is what we see. We place sensors, we see 24/7 data, we see the average glucose, and we see the time in range. So this patient, when she's not checking, she's high. So only 44% of the time that we analyze the data, this patient is achieving goal. When we actually see the graph, and this is what we call AGP, or ambulatory glucose profile. This is specific for DESCOM. So here we can see the average, we can see the standard deviations, the variability, and more importantly, the median of the blood sugars based on the time of the period of time we are analyzing the data. So this patient has pretty good fasting glucoses. So her glargine and her basal insulin is working fine. The component is postprandial. It's just when she's eating, her blood sugars are high. So definitely it's a more comprehensive, actually, review of data when we have these devices. So interpretation. So now that we know the benefits and we know actually pretty much the basics, that we know the devices that we have, how we obtain the data. So these devices are shareable. So we can have our professional sites and the actually patients, CGMs can be connected to our site, even remote monitoring, especially in the pandemic era. It was very beneficial because of the telehealth, and so we were able to access devices remotely. So when we access, this is actually what we see. So we have a standardized metrics for clinical care. One of the first things actually that we assess is the sufficiency of data. Some sensors can fall or patients do not place it the way they should every 14 days. So the time that the CGM is active, it's very important because it's not the same to analyze only 7 to 20% of the data to have enough. So ideally, it should be 14 days of data, more than 70% of data from those 14 days. And then we have actually the average glucose, the glucose management indicator, which is a pretty much an approximate of the A1C level based on the 14 days data that we have. And then we have the measurement of the glycemic variability, which is a standard deviation of mean, that pretty much less than 36 is considered to be acceptable. So that's how high or low, or the difference actually between the values we can see. This is just analyzing the data sufficiency. And then how GMI compares with the A1C. So definitely this is a mathematical algorithm. So with 14 days of data, we can have between 2,800 to 20,160 glucose values determination, even 10 to 14 days. So it correlates pretty well when we do even A1Cs on blood work for the last 90 days. Of course, this is actually a short-term measurement, but we can even go backwards and analyze the data for 30, for 90 days. What is important actually of this? Sometimes we have challenges with A1C testing, especially, remember, patients that have any problems with their red blood cells, even from chronic kidney disease, pregnancy, patients with anemia, sickle cell trait, any hemoglobin variant. Definitely that will affect how reliable the A1C will be. A1C is just the glycation of the red blood cells in 3 months, even patients after transfusions. So if we have a patient that comes to the office and he just had surgery 1 month ago and he needed to be transfused, that A1C, of course, will not be reliable. So given the limitations that we have in some patients, the fact having a CGM is a much better way to assess actually the blood glucose values and make changes on therapy. Okay, so timing ranges. So as I said, this is actually the most important, definitely one of the most important metrics that we see, and we've been pretty much reviewing that during the whole presentation. But here is how the report will display. Timing range, below range, level 1, which is 70 or below level 2, 54, that is pretty much a little bit, more severe hypoglycemia. And we have above range, level 1, 180, and higher than 250, level 2. What is our expectation, as I explained? Usually in every diabetic is less than 4% of lows. Given heart issues or comorbidities, we expect less than 1%, trying to avoid hypoglycemia. And above, or 25%, as I said, is pretty much above 180. But our expectation minimum is that a patient can keep like 70 or above. As I said, we already reviewed these metrics about the average glucose and so forth. So this is how the actually report. This is a Libre. It's pretty similar for all the devices, and we see everything combined. So we have the metrics, the timing ranges, and we have the ambulatory glucose profile, or pretty much actually the average of the glucose for 24 hours. So you see actually the numbers per hour. Here you have the daily glucose profile. As you can see here, just on this patient, definitely you see how one day we didn't have data. Probably the patient didn't place the sensor or had an issue with the sensor, or we have actually missed trace that also could represent if a patient has an intermittent scanner, is not scanning appropriately, or they can have communications issues in between the sensor and the phone. But this is actually give us a daily profile. So here, just interpret, like reviewing this, first of all, we have 60% of data. So we know already that there are a few days that patients, or we don't have data, or patients did not wear the sensor. So that's important. Second, we see the percentage of low that is specifically, for example, this patient has. This patient, the timing range is excellent. 87% has an A1C of 5.7%, but if we see 12% of the time below 70 is concerning. So if you see actually the AGP, as I'm pointing here, you see pretty much all the episodes of hypoglycemia overnight that this patient is actually having. If he's on basal insulin, that means that we need to start making some changes and decrease basal insulin due to nocturnal hypoglycemia. So just finalizing to address patterns. Also, hypoglycemia is one of the first, actually most important things to avoid on every diabetic patient. So we need to assess if the patients are missing meals, decrease or stop medications in our case. We need to consider the use of medications that will not increase the likelihood of hypoglycemia, insulin or, sulfonylureas or medications actually like that. They will give you the possibility of make changes on basal or pre-meal insulin dosages. Also, exercise timing. That's very good tool also in patients to know, because the changes of insulin sensitivity related to exercises can be seen as a hypoglycemia post-exercise, or mismatches in between painkiller insulin, carbohydrate meal intake. So it can give you the opportunity to learn a lot about patients' behaviors as well. And of course, if you have a timing range that is not good, first, if the patient is compliant, second, we need to adjust the medication, or definitely see what is happening with the meals, or if a patient is on insulin, if the patient is dosing before eating and not doing it after. But well, in summary, just to finalize, definitely diabetes technology have rapidly changed and evolved, especially in the last 10 years. So what we have seen is improving of the quality of life of our patients, life expectancy, and that has actually a lot of benefits in terms of prevention or, microvascular and complications overall. So now CGM is a standard of care. It's cost effective. So definitely, actually, although definitely they're not, some patients actually insurances could not cover and things like that, but definitely just looking at what they improve, reducing the hypoglycemia risk or decreasing the variability, some patients even consider is very reasonable. CGM should be encouraged actually to be prescribed in the primary care setting by internists, by family medicine providers, because in our field, most of the diabetes management happens, and it's done by internists. So definitely we're expanding actually the knowledge of these devices to everybody that treats diabetic patients. Even if actually studies cost analysis that they have done, even the CGM cost per day is, you can see, 2.59 versus 11 based on the supplies that the patients might need with finger sticks, for finger sticks, like the strips, the meters, the solution that they use, the lancets. And definitely advanced technologies provide definitely a safe, comprehensive approach to glycemic management. And we have seen that patients using this kind of technology, we have improvement of A1C, the reduction of hypoglycemia, and quality of life. So now, even there's so many, within the last year, there was different approvals of pumps and different technology. So as it is becoming a standard of care for insulin-requiring diabetes, also we have seen that the need for trials and information and guidance for all the physicians that treat diabetes also has increased. But definitely it's an excellent tool to assess for diabetes, management and treatment. But well, that's all.
You may exit the screen, Dr. Escalona. What a wonderful recap you have given us. Thank you so much. It is incredible the way diabetes management, diagnosing, treating, and monitoring has evolved in the past 10, I would say even more, 15 years. It has been exponential. And just to put things in context, one of the things that you as an endocrinologist is helping in the global management of this very challenging condition is perhaps one of the best kept secrets that we have in medicine. We know that nowadays the non-communicable diseases alone, including diabetes and the consequences of diabetes, has put a tremendous burden in our healthcare system. And diabetes nowadays is perhaps one of the leading causes of those major non-communicable diseases. As a matter of fact, if I may quote the prevalence through the International Diabetes Federation, I remember back in 2019, they were estimating that 463 million people were living with diabetes between the ages of 29 and 79. And then we all panicked at the time and said, oh my goodness, what is it going to be in 2040? How is this going to correlate to our economic burden currently in our healthcare system? And then you incredibly highlight in your recap the cost of actually using technology to leverage the treatment and allow patients to actually have a better quality of life. $2, and I think you said $2.55 versus $11 a day. I mean, my goodness, in comparison to the amount of money that we are paying on managing diabetes in the traditional ways. So it is incredible what the new technology has done. And I commend you for actually being the promoter and helping us all understand how can we manage our patients with this technology. And I know for a fact that once we put a technology out, it's extremely expensive at the beginning, but then cost because of volume and because of production will decrease eventually. And hopefully that is the ultimate goal for all of us. Now, I wanted to just point out, Dr. Escalona, that obviously in our countries, in the Latin American countries and in developing countries, some of these technologies might not necessarily exist. And of course, you as an endocrinologist and having the vision for the Diabetes Association goal for 20 years from now, it is to decrease it or stop it or cure it if possible. What is what are you most excited about? I know you mentioned, for instance, Stello, that is going to be in the market in the summer, which is very exciting. At least we get to know what our glucose level is. But what are you excited? What are you most excited about with the new technology that is coming on board?
Well, definitely bionic pancreas. So actually, they have been working for the last few years. Even actually, the device, which is called iLet, was approved for insulin delivery only. So, of course, technology in terms of insulin delivery is a different, thing. But definitely, insulin pumps now are getting, to say it that way, better in communication with these devices. So they make actually the delivery of insulin is a little bit more automatic rather than the way we used to program actually settings on an insulin pump. So the newest one that was approved at the end of last year is now becoming available, which is iLet, is actually the one that is an insulin pump that you just put your weight and everything is done by the system. All the traditional pumps, patients needs to actually, now things has been evolving to the point that insulin rates per hour adjust by itself, just based on communication. Is an algorithm with the continuous glucose monitor. The algorithm is extremely well designed to avoid hypoglycemia with suspensions of insulin without patients even knowing. So I think this is very exciting because even since the approval of the first insulin pump that it was doing automated delivery in 2016, so it hasn't been that long. We have tons of actually like more than 5-6 devices, and every year one is even getting better than the previous generation. So definitely I think everything is leading just for the approval and actually finalized, because for a bionic pancreas you just need not only to be able to deliver insulin, you need to deliver actually glucagon, which is the hormone that actually gets up for people to prevent hypoglycemia. So that's what they're working actually right now in clinical trials just to make this happen. So
that is so exciting that you mentioned that you are at that stage. I remember, I want to say 15 years ago, perhaps, when University of Miami, through the Diabetes Research Network, they were talking about islet transplantation from the pancreas directly into the liver for it to be.
And they do any selected patients, but of
Yes, they
course,
still
actually,
do.
sometimes they they do not work. Or even we have patients actually that they have kidney pancreas transplantation at the same time. I have had a few patients with type 1 that they are seeing Massachusetts General Hospital and they go kidney and pancreas transplantation, these patients pretty much diabetes is gone, especially type 1. But to get to that point, you need to have all the criteria to be eligible for a transplant. So patients with kidney disease and things like that. But just actually artificially speaking, so that you can have a pump that can work as a pancreas without the minimal interventions of the patient, I think it's a great. Yeah, actually.
It is amazing, an amazing undertaking. And the fact of the matter is that, I mean, not to diminish the amount of work that the scientists have invested in actually creating and taking the islet cells from cadavers and implant them in livers and so on, and monitor and prevent rejection, to actually having a technology that can obviously now support the body in that endeavor. And not even talking about what we have in our hands in the past year, which is artificial intelligence. Now, your office can definitely get a conglomerate of information, monitor it through your office, and also deliver that result directly to organizations that require the outcomes from the devices that you are obviously using for the treatment. Nothing. Continuous glucose monitoring is in my mind evolving. It is in early stages in my mind, again, despite the fact that we have gone through so many models. And now I love this Stellum model. I can't wait, especially when you, for instance, as an endocrinologist, say, you know what, you're pre-diabetic. You need to start checking.
And that's what happened, actually. The issue, actually, especially here in the United States, is approval. Okay, so even it has been changing. They have seen so much benefits, as you said, at the end will be more cost effective than having somebody coming with PKA, or even a type 2 diabetes having complications later on from diabetes, like kidney disease and so forth. So now even plans like, even Medicare, CMS, Medicaid, Medicare, they're covering these devices. And they used to cover only for insulin-treated people. Now they're expanding, actually, the coverage for these patients to get these devices. So it has been like in the last 3 years, yes.
I know they have gotten smart, because they say, well, where are we to do? We know what is coming. We have to do something in prevention. And this is technology that we have available. We can definitely make it cheaper eventually. Why not use it? So I think that the actual conundrum is basically how to identify those patients at this point in order for them to start using these different devices. The smart insulin pens, for instance, was one that also had a little buzz. I don't know how you feel about that particular technology, and have you used it in your office?
Not yet, actually. So the islet, you mean? No, we have had a few patients with it. They practice, a few of my partners. It's just one or two, but definitely it's new. But as I said, this is just insulin delivery. It's not actually that's the only, part that has been approved by the FDA so far, but at least it doesn't require any intervention by the patient. Before, the patients need to be, okay, I need to count how many carbs I'm going to eat, and then they put the carbs, and then the pump, that's a calculation. But everything in terms of mealtime delivery insulin is done and initiated by the patient in most of the devices. This is the only one that you bypass that. You just put the weight of the patient, that start gathering information, works with Dexcom, and then the patient just eats. They don't need to be counting. They don't need to do. But personally, we have had only a couple of patients. It's a very new device. Yes.
Very new device. Yes. And I love how much in your armamentarium you currently have, not only these incredible technology and devices, but also the new medications. We have heard so much of the GLP-1s,
exactly,
and obviously there's GLT-2s and all that, and the combination of both, and the oral. I mean, it is incredible how the paradigm is actually shifting. And now obesity is being looked into completely different lens.
Exactly. Yeah.
But what are your thoughts about the use of GLP-1 inhibitors in regards to obesity?
Definitely. Well, the data is there. So definitely we need to understand that not only obesity will be actually a leading risk factors for diabetes itself, for cardiovascular conditions, sleep apnea. So it's a lot of actually of morbidity related to obesity. Even actually, we have had patients like with joint issues, osteoarthritis, or even patients that need actually to get procedures after some treatments. And they would like actually for them to have a better weight. The challenge actually remains if you have a patient that is a good candidate and definitely meet criteria. And yes, I think I am actually in pro of treating the patients. The challenge that was seen, especially that the approval of these medications was very recent, especially Zepbound, which is tirzepatide, that was approved actually back in November. But it's just the coverage. So even not every plan considers like this criteria or obesity, there are exclusions. That is the main challenge, but the medications actually work. The only thing is patient understanding. Every medication will have side effects. Yeah, these ones they
eventually.
also have contraindications, implication, and most importantly, length of therapy. I always explain that patients actually seeking for weight loss. This is a medication that they have not been more for weight management. One of the leading ones, they have not been more than 5 years, so which is semaglutide. So for weight loss, so the data that we have just from clinical trials is that patients tend to regain the weight loss after discontinuation of therapy. So this is not a medication that you are intended to take just to lose the weight. It's expected for patients to take it as in treating obesity as a chronic medical condition, same as hypertension or obesity, but the medications work. Yes, especially with patients, I think, with comorbidities, pre-diabetes, hypertension. So definitely we have seen pretty good results in this matter.
Yeah, and it's worth mentioning again that we still have insufficient data in regards to side effects and complications, so what have you.
Yeah, so the data that we have is from clinical trials, but
Yeah.
remember that is actually what granted the approval, but long-term data, yes, we don't have.
Yeah, we're still the jury is still out. And finally, just to recapitulate and to recall some of the comments that we have had in the past in some conferences, which is, well, is the GLP inhibitors are going to substitute eventually bariatric surgery. So yeah, what is your thought on that? And what's your
Well,
hope?
it depends actually. It depends, of course.
Yeah.
If definitely this medication works, but we have data, we have percentage of weight loss based on the peak weight on clinical trials. If someone actually is morbidly obese, probably we will not achieve the weight loss that the patient can benefit with bariatric surgery. Yes, but I have a lot of patients that definitely we see good results even in preparation for bariatric surgery. So definitely, I don't think, well, so far we don't know if it's going to substitute, but it depends actually of how the weight of the patients, if the obesity is more, like morbid, BMI is even more than 50. So those patients actually that probably, I have seen patients after bariatric surgery that they have lost 150 pounds.
Yes, yes, we
So
have.
exactly. So definitely the efficacy to say that way in
Yes,
terms of
yeah,
weight loss will not be comparable with this kind of procedures, but we're
absolutely.
talking about a medication that can be stopped. This is a procedure that definitely is a surgery, is a
It's permanent.
change the anatomy. Yeah, it has long-term implications because of the, the way, the nature of the procedure. But bariatric surgery, yes, it's a metabolic procedure, and we have seen significant improvement, not only on weight, even on patients with diabetes.
With diabetes.
I have patients that they have need more than 150 units of insulin just to be able to control diabetes, morbid obesity, liver disease. So definitely there are patients that will continue to benefit from this procedure compared to be on, on GLP-1s. All right.
Dr. Escalona, this is not the last of our conversation. This is just the surface, scratching the surface on diabetes. And I love that you thought of technology as a way of creating conversation and interest. And I encourage all our physicians and the physicians abroad that have thought of including technology to start learning more about it because it is paying great dividends, at least here in the States. With that, I have taken enough of your time. You've been more than generous, and I want to thank you on behalf of our international team for accepting our invitation once again, for the incredible presentation, and for your availability always to us. To all of those that have joined us and will be joining in the future, I would like to invite you to send any questions that you may have about the presentation or the technology that you heard today from Dr. Escalona to BHIWebinars@baptisthealth.net. That is BHIWebinars@baptisthealth.net. We will be more than happy to send them to Dr. Escalona for her to review and respond back to you. Thank you so very much. We look forward to seeing you in our next medical lecture series scheduled for August 21st, 2024. Thank you again and have a great, great evening. Thank you, Dr. Escalona.
Thank you for the invitation. Happy to be here. Thank you.
Our pleasure. Thank you.
Thank you.